present reality that we are in a new normal of political correctness. And so when we think about who gets ketamine for excited delirium, it's usually somebody that is very, very agitated, that may or may not have had a police interaction, but most likely a police interaction. And so already a tough environment. And then you give a medicine to somebody, and remember, everything's kind of like 20/20 in hindsight, but you never know what you're getting when you get somebody that you're going to administer ketamine to. And what I mean by that, if somebody comes in and they're being held down by 9 police officers and they just tore a house apart, and you know nothing else except the fact that there's 9 people holding them down, you're terrified about positional asphyxia, you recognize the possibility that this person could be in rhabdomyolysis or muscle breakdown from the restraints of police, and you have a couple medications that you can give for sedation, and that would be your benzodiazepines, things like midazolam or Ativan, both of which cause respiratory sedation. You also have ketamine, which in hopefully normal circumstances doesn't cause respiratory sedation, but you know that you have somebody that you know very little about that is acutely agitated, that may have overdosed on either opiates, on benzodiazepines, but they're really acting like maybe they didn't do that. Like they're acting more like a cocaine or a methamphetamine. And so you hope that it doesn't cause respiratory sedation, but you give the ketamine anyhow. And so the patient, you're really kind of shooting it into the night because you don't know what exactly the patient's done, but you know you need to get control of this really, really violent person. So ketamine has been approved for several years for the treatment of excited delirium, and in doing so, it's been very, very effective. But unfortunately, in some areas of the country, it has been perhaps misused, where somebody is under control and police have asked for restraint of a person even though they don't really meet the criteria. If we remember the MCRAS scores, they're not acutely agitated and they get ketamine anyhow. And so the anesthesiologists from Colorado, their society, have questioned the use of ketamine in EMS. ACEP is looking at the use of ketamine in EMS, specifically for excited delirium. NEMSP has done a position paper of that ketamine is in fact a safe and effective medication for excited delirium. But then again, we have to realize that the term excited delirium is not recognized by everybody in the United States. Emergency medicine tends to recognize it. The psychiatrists, the American Academy of Psychiatrists, do not recognize excited delirium as a viable term. I believe the Medical Examiners Society has recognized it as a term. And what is excited delirium? That's when somebody is just completely wild. They exhibit signs of extreme violence, extreme rage, extreme power, what we call psychomotor restlessness. And so ketamine is used as a mechanism to dissociate the person and get them into a position of control where we can establish IV access, add additional sedatives to the patient if necessary, and then get whatever diagnostic testing is necessary, whether it's laboratory testing, CBC, CMP, alcohol levels, tox screens, or CAT scan of the head and other diagnostics for the patient. So anyhow, there is a number of people that want to get rid of ketamine just because there has been some misuses, and that's why our state requires every use of ketamine be documented and sent to the Federation and up to the state EMS office. So we track each and every case for appropriateness of administration. I sent a nice review paper from NEMSP, kind of going through all the positives of ketamine. Ketamine is a highly efficient induction agent for intubation, and I believe Bob Hollinger asked I think it was Bob, is there a possibility that it could replace etomidate? Right now, there's pilot projects within Pennsylvania looking at etomidate versus ketamine, and those have not been published yet, but there is quite a bit of interest in ketamine for airway management. It is a preferred. I use it a lot in the emergency department for respiratory distress because it's a bronchodilator, has very little effect on blood pressure, and I'm probably about 70% ketamine, 30%, I'm sorry, 70% etomidate, 30% ketamine. The only reason I tend towards etomidate is just because I've used it for so long, super comfortable with it. There is some issues of spasm, laryngeal spasm. If you push the ketamine too quickly, typically that can be a self-limited thing where you just bag the person through it. We know that the higher concentrations are more likely to cause issues with laryngeal spasm. But if I was a betting man, ketamine will either replace or be added to your drug list as a potential for intubation. The nice thing about having ketamine as opposed to etomidate is you really have three uses for ketamine. You can use it for subdissociative doses for pain management. You can also have it for your induction agent for intubation, and then for excited delirium. So the NEMSP paper, it's I think very worthwhile, and it was actually reviewed as one of the top 5 EMS papers this year. So Rick will send that out, and if there's additional questions after you read it, just let me know. Does that answer the question relative to ketamine?
I believe so, yes. And like I said, I just got that the other day, as well as the other 5 most interesting articles of 2020. So I'll get those out to everybody. I haven't had a chance to read them, or I watched the first one. So yeah. So the next question here comes from John McCafferty, and I did find your presentation. I do have it. So this is the last question that was presented to us, Dr. Mike. So we'll get through this one, and then I'll go ahead and pop up your presentation.
Okay.
So, John McCafferty asked, interim ALS protocols for COVID on the PA Department of Health website should state that we should not be giving steroids for suspected COVID. Is this recommendation outdated at this point, with studies showing that they are beneficial? Currently, we are advised to not give Solu-Medrol, but it seems that this could actually be good for the patient in recent studies. Your take on that?
So it's a great question, and so what we don't know is there is a benefit to steroids, but we don't know if early administration of steroids are important, and we don't know how long those steroids last as far as the duration of treatment. So, for instance, when I had COVID, I was given 10 milligrams of Decadron every day for 10 days. And I can tell you, I'm a pretty high-strung guy as it is, and then taking 10 milligrams of Decadron every day for 10 days, insomnia, restlessness, kind of agitation, not super pleasant. So as far as EMS, we know that there is a benefit, but we don't know, is that going to be for the hospitalized patient, for the outpatient management of it, and is it critically important to be given by EMS in the first few minutes to hour of treatment. So I think for now we're still learning what's best practices for the treatment of COVID-19 within the emergency department. And the patients that I see and discharge, they do not go home on prednisone, or they don't go home on Decadron. It's really reserved for those patients that are hospitalized, and the true benefit is really that 10 days of therapy, unless there's some new studies out there, and I doubt that there's really a whole lot because we're dealing with a virus that we've really only had experience with for about a year. So right now, I don't think it's critical for EMS to give steroids.
Mike, do you want to, if everyone is not aware, Dr. Mike did have COVID. Mike, do you want to share a couple of your experiences being COVID positive, and what your treatment over your time and everything, and where potentially you were exposed from it?
Sure, sure. So I was contact traced back to the emergency department. So somewhere in the zillions of patients that I saw or staff members, I really had no other exposures because, like all of us, we don't do anything. I don't. I don't go to restaurants. My kids are in public school, but they did not have, nor have they tested positive for COVID, nor my wife. So I had limited contact. So I was contact traced back to the emergency department. No blames. It's occupational hazard. I think from an EMS perspective, it was kind of interesting how I started getting sick and how subtle it was because it was in November. I was diagnosed November 22nd, and it had been warm the day before, and I wanted to get one last mowing in. So I mowed the field, and I have asthma. And with the last two swipes, I was in a hurry, and I got a big lungful of kind of grass dust and everything else. And so the next day, I noticed that I had a dry cough, which would not have been dissimilar from any other kind of mild asthma exacerbation. So I went to work. I felt fine, but had this kind of nagging cough, and everybody kind of looked at me, and I was like, no, I was mowing. I don't feel bad. But then as the day went on, I was like, holy crap, I still have this cough. Maybe I should check my temperature again. And so I had no temperature. By the time I went home, I had a temperature of 103.5, felt horrific, and then started getting some fairly significant chest burning and shortness of breath. I talked to my internist, and he felt that I would benefit from hospitalization. So I was hospitalized for 5 days. Why? Because I received IV remdesivir, which is an HIV medication that causes liver failure. So it's a really exciting medicine to get. So they checked my liver enzymes every day, make sure that my liver wasn't damaged. I was given the IV remdesivir, and it worked. The one thing that was, to John's question, that was really something else is my first dose of Decadron. As I got my first dose of remdesivir and my first dose of Decadron, and that night around 2 a.m., I felt almost complete relief from my arthralgias. My fevers were down, my burning, my chest were gone, and I know this will make Dick laugh, but I felt like Donald Trump saying the China virus is leaving my body. And it really was. It was the most bizarre feeling. And I know, kind of, with, I'm sure, Donald Trump's megalomania, that he really felt amazing. And the steroids initially do make you feel pretty darn good. And so that was very, very interesting. The next day, I was given the option to receive convalescent plasma, which is essentially plasma taken from COVID positive patients, and the antibodies are administered via plasma back to you. So the first time I ever had a blood transfusion, they know that the earlier it's given, they think there's some benefit. When I got it, they had never quantified how many antibodies were in that, but they're doing that now. And so I received convalescent plasma, and at day 5, I had completed my dose of remdesivir, and then I had to finish up my 10-day course of Decadron. So I was blessed to have a cabin. I went to my cabin and spent the rest of the recovery there, which was actually fairly miserable because I couldn't breathe. I couldn't do hardly anything. I had a resting pulse ox right around 90, and that certainly went down very quickly with anything. I was very fatigued. And so in addition to that, I was on day 7, 8, 9 of Decadron, which caused a hell of a lot of restlessness. And it's not a big cabin, and when you can't breathe, you just got to walk around. It was not good. But the nice thing is I felt very blessed that somebody was kind enough to donate convalescent plasma. I got better. The one thing that is probably a teaching point for EMS is that day 7 is when people really do poorly. So you'll get sick, say Monday, and by Sunday you start turning the corner and decompensate. And we see this with our patients. And most of the patients that I'm seeing, that come in the emergency department and are really sick or hypoxic or right around day 7. So when I was hospitalized, it was kind of creepy because I would see patients getting wheeled off the floor to the ICU for intubation fairly frequently, and I just was waiting for that day 7 to figure out whether I was going to crump or not. And it's kind of sober. It's very sobering. And so, just as a provider, you just realize that it's very scary. And for those that had it, it can be very scary. I think Bob May said something very interesting today during our board meeting, and that was that patients are so overwhelmed sometimes when they get the vaccine that they break down and cry. So there is a huge emotional component to the COVID infection and just the threat of having COVID. And then probably the last part of that is just normally the average number of ER visits to get hospitalized for a COVID infection are 3. So you come into the emergency department the first time and you're diagnosed and you feel like hell, but you don't meet the criteria. And really the biggest criteria that we've been using is hypoxia, so a number less than 90 to get hospitalized for oxygen. And sometimes that takes a couple of days or to that day 7 to actually get hospitalized. So just a kind of interesting side note, 3 visits before you get hospitalized. So that's pretty much my experience with COVID-19.
All right.
So
Anybody have any questions for Dr. Rehart regarding his COVID?
I just want to follow this up with, as people are thinking of questions, whether you should get vaccinated or not vaccinated. I just did an interview with Fox 43, and I've looked pretty hard at vaccinations. And there's a couple questions that come up. Are they safe, and how did we get a vaccine so quickly? And if you if you look at the science behind the vaccine, our infrastructure was up and running for coronavirus-like vaccinations, and so there's a lot of research into this and some of the new technology. So it wasn't like we were starting completely from scratch, but oftentimes to get approval of a vaccine can almost always takes anywhere from 3 to 7 years, and the pharmaceutical companies actually call it the valley of the shadow of death when you're waiting from the initial phase 1 trials to the phase 3 trials. And in the meantime, that virus could not be a threat anymore in 7 years. There's no profit to giving the vaccine, or just there's just loss of interest, or there's so many bureaucratic barriers that it just doesn't pay out. So this was really a masterful working between government and private partnerships to get a vaccine within a year. I believe it's safe. I do not believe it is the mark of the devil. I don't think that it causes infertility. What's the other one? Mark of the devil, the radio transmitter chip. I suspect that if anybody's worried about being tracked, it's not because of a virus, but it's because of your cell phone in your hand that follows you everywhere you go. No chips in the head. And really, some people quote that it's only 99.4%, only 0.6% of the patients die from this. But I'll tell you what, you get pretty darn sick, and we have very good ICU level care. So there's a number of patients that in 20, 30, 40s that have no underlying conditions or underlying conditions that become quite ill. I've never seen any virus like this before. This is not influenza. With influenza, you could be sick for a week or so. I know of several EMS providers that have been on oxygen for months afterwards. So when you look at the risk-benefit ratio to a vaccine or getting ill or potentially critically ill or dying, I don't think it's a no-brainer. Get the vaccine. Questions?
All right, I do have a question here that came in through the chat in regards to the vaccine. If we have gotten the current vaccine, do they feel we will need the newer vaccine from Johnson & Johnson or boosters, etc.?
So I think the way this is going to work is this is going to be either included in the flu shot or will be a second shot with flu shots going forward. Coronavirus isn't going to go away anytime soon. So this will be a continued need for vaccination. What I understand with the new variations and the mutant forms of COVID, that these vaccines are effective against them for right now. That's not to say that in 6 months or a year they will, but we know that every year you got to get an influenza shot, so probably every year you're going to have to get a coronavirus shot. But right now, what I understand is these are the effective shots, and they should be effective for probably this calendar year.
Okay. Anything else regarding COVID and Dr. Mike's experience? On a personal note, I lost my ex-brother-in-law. He was 51 years old just after Thanksgiving. And unfortunately, his father had passed away from COVID 3 days prior to Mark passing away. So, yeah, it's and having a wife and son that also work in healthcare and ER, it's blown up. So. All right. I don't have anything else here, Mike. So I have your, can you see I have your presentation up?
Yeah, I think putting my arm around the chair here, now you can all feel like you're sitting in my passenger seat.
There you go.
This is the most bizarre year, but hey, thanks for thanks for doing this. And this is not a beer. This is it looks like a beer, but it's sparkling water. So anyhow,
right.
driving with Dr. Mike. Okay, so hey, I noticed that there was a really big paucity of information relative to the EMS response to civil disturbances, and so I created this PowerPoint presentation. And this is all original research. This came from nowhere except, the literature in my mind, with the hands of Vicki Martin, who assisted in this wonderful PowerPoint presentation. So again, thanks to Vicki. She truly is the wind beneath my wings when I do these fantastic PowerPoint presentations. Vicki doesn't know this, but I sent this to the Department of Health, to Doug Kupis, and he was nice enough to invite me to a national chat, not a chat room, but a national webinar. So on Monday, I gave a 10-minute version of this lecture all across the United States, and talked about the top 10 bullet points relative to civil disturbance and our experiences in South Central Pennsylvania and Lancaster. Next slide. Can you control the slides? Yep, there we go. So, protest is really kind of the legal means of expressing your First Amendment rights. Organized public demonstration of disapproval. But a riot is a disturbance of the peace created by an assemblage of 3 or more people. So it's not a whole lot of people with a common purpose, and then they act in a violent and tumultuous manner to terrorize the public. Next slide. So there's a couple of psychology of riots, and so there's really 3 of these things. And one is they're highly controversial because all sorts of kind of weird things happen in a riot. But there's the mad mob theory, where individuals lose their sense of self, reason, and rationality, and do things as a group that they wouldn't do as an individual. So we all know about the concept of groupthink, and when you get into a crowd, there's a feeling of anonymity, and perhaps you would do things collectively that you wouldn't do as an individual. Next slide. So then there's collective violence, which is a product of the convergence of criminal elements enacting their violent predisposition in the same space. So we see this even in Lancaster, where we have well-meaning people end up with some non-well-meaning people. Oftentimes these people will come from outside of the area, whether it's Lancaster or some of our big metropolitan areas, with intent to create havoc and destruction. And then there's a third combination of riots, next slide, which is really the bad leading the mad, where you have these unscrupulous outsiders come in. They take advantage of the gullibility of the crowd. They use them as a tool for destruction. And it's really a combination of the mad mob. So it's somewhat controversial, but when you see how things play out, there's probably some truth to these 3 things. Next slide. So The one thing that people will say is, well, you know, it's mindless. There was no intention. Things just got out of control. But typically, it's never mindless. There are people in that crowd that have a idea of what they want to accomplish, and it can be very well orchestrated. Social media has been a very powerful tool to bring people together, and now to pre-plan their riotous activities. And now we're actually seeing encrypted social media sites. So early on, the police were very good about getting into social media and seeing what was happening. And now it's a lot more difficult. The riders have a pretty significant infrastructure, including medics. If anybody have been at any of the demonstrations, we have seen people dressed in, you know, headgear, and will have red crosses or some sort of identifying thing that they are part of the medical team for the protesters or rioters. There'll be supply chains, including milk for chemical decon. And when I was down in Lancaster, we saw all these people carrying in gallons of milk, and we're like, what the heck are they going to do with gallons of milk? Well, it's very effective when you get pepper sprayed to treat your pepper spray with milk. The fat in the milk helps decon yourself. They'll carry bottles of water, and this is across the country. If you freeze them, they make a perfect rock, or they make a perfect brick. If you get stopped by the police and you got a frozen water bottle and it's hot outside, you're just waiting for it to thaw out. So it's not nearly as inflammatory as a brick, but they will smash windows. And if you're there long enough and you're thirsty, you can drink your bottle of water. So very well organized. Next slide. So 3 levels of civil disobedience. There's passive unlawful assembly, which is nonviolent. That's where people may sit down, they may pray, they may sing, but they're really not doing anything. And then you get into the violent riotous behavior, and then you can actually go to complete anarchy, where you start burning down a town. Next slide. So some of the crowd control measures for law enforcement, you're going to isolate the crowd. You want to show a force. You know, in Washington, D.C., as a commentary, we see that there was a stand down order, no preparation for a show of force when the Capitol was stormed, and that's unfortunate on multiple levels. But there's you will want to go and selectively arrest people or do multiple arrests. It's very easy sometimes to see who are the troublemakers in the crowd, and if you go after them first, that can oftentimes be effective at helping disperse the riot. And then the actual active dispersal can be with a forced movement towards the crowd. You can bring horses in, or you can use chemicals or other things to dissuade people from rioting. Next slide. So it's expensive, $1 billion plus in riot damages here. It's the most expensive in the history of insurance things. 140 cities had demonstrations, but most of them were nonviolent. But when you think about it, there was vandalism, looting, some police-involved shootings. 9,000 people were arrested. And if you think about that, this time last year, there was 9,000 people. Many had no criminal record, and now there's 9,000 people, which could have up to felony charges based on some bad decisions by going to riots. Next slide. So again, the cost has been amazing, $1 to $2 million. The insurance industry is actually looking at this and have considered what's called a multi-state catastrophe. 25 related deaths, 700 police officers injured, and 2 killed. And actually, this presentation was done before the Washington D.C. riot, so at least 3 killed now. Go ahead, next slide. This is in Baltimore. You can see them crawling on top of the police car, and again, the most expensive year in history. Next slide. So for you guys, what's important? And these pictures are from Philadelphia, so 90 miles from here, and you can see there's a lot of fire, right? They like fire, and even in Lancaster, we saw them lighting trees on fire. It's kind of interesting that people that were lighting trees on fire are typically the people that hug trees. But that night they thought it was important to light a tree on fire. So for you guys, you guys and girls, I guess this year, though, we're going to just say you people. So personal protection, you want to work in pairs. You want to make sure you have good radio communication, make sure your batteries are charged. You have redundant batteries. You want to have staff accountability. You want to secure your stations and recognize that just because you're in an EMS station or a fire station, that is not going to have the crowd bypass you. This is really about maximum destruction, about anarchy, and so fire stations are potential places to be burned down. I was talking to some of the chiefs, fire chiefs from around the nation, a conference call a couple months ago, and they made the point that $500,000 engine or more is just they don't care. They'll light it on fire just like anything else. And one of the reasons is many of these people, as I said before, are not from the area. So if they come in and burn down all the fire stations in the neighborhood, they can go back to a place 40 or 50 miles away where they have intact fire stations. You may consider removing some of your non-essential equipment with the idea that your vehicle may be taken or destroyed. When in Lancaster, we saw the coroner's van, brand new coroner's van. I'm not sure who gets mad at a coroner, but they smashed the windows out and were in the process of trying to light it on fire when a police officer was able to use a common key and get the vehicle out of there. So pretty much anything is game. So do not underestimate the desire for destruction of property. Next slide. You want to make sure you have a full tank of gas. You want to make sure you have all the appropriate PPE. You want to coordinate with your health system. I think that was paramount, to let LGH know what's going on. You also want to talk to police, fire, and community leaders. This is preferable before the event. When the event happens, things are out of control. Activating the EOC and having active incident command did not happen very effectively with some of our riots. So very, very important. You may need to modify EMS operations and allow people to non-traditionally transport themselves to the hospital. At the very end of one of our riots, it was just too dangerous. And so we let people, and there wasn't a whole lot to come, but those people could make the decision to walk to the hospital. You may also want to realize that you could have potential for mass decontamination from your chemical munitions, or you could have casualties from either gunshot wounds or ramming injuries. Next slide. So scene safety, just like with the rescue task force model or SWAT medicine, you really have three layers. You got your cold zone, which is your staging area or your outer perimeter. And then you have the warm zone, which is just a little bit dangerous. And then the hot zone, which would be your very, very dangerous area. There would be no reason I would see for EMS to enter the warm or hot zone during a riot, especially because of the dynamic situation of a riot. You can see people literally move several blocks in one direction or in other direction very quickly. So you could be very much overrun. So that's why you have to have robust communication with your police units and know where a good casualty collection point is or a good safe cold zone, and realize just because it's a safe cold zone at 2 o'clock in the afternoon, at 2:30 it may be a hot zone. Next slide. So we all know about the rescue task force model. In the old days, you kind of would stage and wait for everybody to come out. We now have a new model, and you're aware of that, where you'll move with typically 3 police officers kind of in a wedge-shaped form. You'll have police and EMS move together to a warm zone to render care and extract the person. Most of these rescue task force models, though, have been described in closed buildings where you have concealment and cover. When we have a riot, there is essentially no concealment or cover. And so the experts are still kind of out deciding what is the best approach with the rescue task force model for riots. We do have embedded medics from the SWAT team that were present during the riots in Lancaster. and they were there, but there's there's only 3 or 4 of them, and they're really there for the worst of the injured. So again, this may be the model where if somebody is injured, that they and their friends extract them to a point where it's safe to render care. But to go into the middle of 150 or 200 people with an ambulance, don't do it. I ask that it not happen with our rides this summer because it's just a recipe to lose your vehicle or to be severely injured. Next slide. So we have about 15 minutes left. This is an hour lecture by itself, so I'm going to kind of go fast, but I think it's worthwhile looking at some of the injuries that both riders get that can be induced by law enforcement and what the law enforcement get from riders. So as you can see here, this in the front slide, you can see a guy grabbing his belly. He's just been shot by AR-15, and the kid's name eluded me, but he's the 17-year-old that decided to take an AR-15 to a riot. Just a very, very bad choice. And I guess this guy had a skateboard and had hit him over the head, and then this kid uses lethal force to shoot him in the belly. So a very sad picture, but reminiscent of what actually can happen. Next slide. So all sorts of injuries, blunt trauma, rocks, bricks. We've seen even in Lancaster, rocks and bricks have been hidden in bushes before the event. Clubs, and if you go online and look at some of the clubs that are being used out in Portland, they're wrapped with nails and they look like something out of the Middle Ages to cause maximum injury and damage to police officers. Trampling injuries, so you can have trampling injuries from just the crowd running, or being run over, or remember, police horses are also used, so there's a potential for that. Thermal and blast injuries, Molotov cocktails are very common. What is a Molotov cocktail? Glass bottle filled with a flammable liquid, typically gasoline, then lit on fire. And now we are also seeing commercial fireworks. So the Longs Park fireworks, instead of going up in the air, are aimed at police. The federal building in Portland is just amazing. Every night for 90 straight days, these guys had commercial fireworks shot at them. And then within the crowd, people will use chemicals, acids, bases, your alkali, anything to throw and cause caustic injuries. We also say anything nasty. So it's not uncommon to have urine, feces, or anything else thrown. And then you add in a pandemic of COVID-19, it can be a bio-terrorist mess. Next slide. So this is the one that really keeps me up at night. Actually, there's a lot of things that keep me up at night, but truck attacks are horrible. And so as you can see in the what would be if the left-hand slide, or if you're looking at it the other way, the right-hand slide, but it says truck attacks. This is a straight truck, and they can easily be rented. Ryder sells them or whatever. And there's actual specific directions on the terrorist handbooks of how to use a truck in a vehicle-borne attack. And they're telling you what the right vehicle is. They also tell you to get up on the sidewalk for maximum damage. And typically these people in Europe, because there's less firearms there, will be armed with knives. And they often will try to disappear into the crowd. So they'll run over everybody. But when you talk about staying up at night and worrying at night, think about the injuries that are potential from a straight truck and 1,000 people in a crowd. So first of all, you're going to have the blunt injuries as the truck hits you, but then people get struck and will go up underneath the engine compartment, so they'll have burns. The truck will wreck, so typically hot fluids can run down on people. They get stuck underneath the wheel wells, and whether they're alive or dead will need to be extracted. And then you add in maybe some explosives in the truck as a secondary device, and you can kill thousands. So very, very concerning. We have not seen the big straight trucks as much here in the United States, but we have seen a number of cars drive into crowds. And again, you can get a lot of people injured very, very quickly.
Mike, isn't it true also just with what happened in Nashville with the RV?
Yes. So that's another good question. I think that the latest I heard that he filled that up with propane, and he he did something that he wanted to blow up the AT&T building for a reason, but he could have done something much differently. And that is, he could have made something very enticing that everybody came up and stood around his truck, and then just blew everybody to smithereens. So at least he put a warning out that, hey, 30 minutes, this thing's going to blow up. And in fact, it did. But yeah, you bring up a very good point. And then the other question for EMS providers is, does the history match the injury? And if somebody says, this happened, but your spider sense says this guy's not acting right, he doesn't have the injuries that everybody else has, maybe he's one of the perpetrators. So just keep that in the back of your mind. Next slide. So there's a firework going off. Here's our law enforcement officers. Lots of use of lasers, even in Lancaster, and these green lasers can be quite high potency. If you look at the available eye protection for lasers, especially high potency, it's not great. A good pair of glasses is over $300 and still does not completely protect the eye. In the upper right hand corner, you can see a Molotov cocktail. And I think we hit, I'm just looking here. Yeah, and then the last part of this is just the psychological damage of repeated days of riots. The police officers, imagine every day you wake up for 90 straight days and you have to have feces thrown on you and laser shining in your eyes. So associated depression, suicide, alcohol and drug abuse. And then the last part of this is, remember, this is an active crime scene. So just be careful in how you tread when you're there. Okay, next slide. So we have rider injuries. We have tasers, baton and nightstick injuries. The beanbag rounds, which are called kinetic impact projectiles, rubber bullets, they can strike the eyes, they can break skulls, they can cause collapsed lungs. And then you have your mucosal irritants like pepper spray, CS, and CN. Next slide. So real quick, taser, it deploys at 55 meters per second. It gives 50,000 volts of energy. It delivers 5-second shots. 80% of law enforcement use it at a very low level of engagement with somebody. So it can be used at the level of pepper spray. So it's not too hard to get tased. Next slide. So 18,000 law enforcement agencies use it. It has been very effective at decreasing injuries to both offenders and officers. We saw in Philadelphia where they didn't have tasers, a guy came out with a knife. They shot him. Why did they shoot him? Because that's all they had to protect themselves. We have a taser, even though knife is considered a lethal weapon, there are some choices that you could potentially use a less lethal weapon to stop the aggression. So the one thing that's kind of interesting is tasers deployed about 620 times per day. They're considered safe, but it's based on controversial evidence. The company claims that 161,000 lives have been saved. Next slide.
Mike, just off the top of your head, what does taser mean again? I believe you told us that it had origins in a comic book back in the 50s or 60s.
It's actually a book, and Dick probably read it, and that's called Thomas A. Swift's Electric Rifle. So do you remember Tom Swift? You don't remember Tom Swift? Yeah, there was the Hardy Boys, there's Tom Swift, and I was not nearly as old as Dick, but I used to read my dad's books of Tom Swift. And the thing that Tom was a guy that he went on all sorts of adventures, and sometimes he went into harm's way. And it would have been bad form for a little kid to have like an AK-47 and gun somebody down. So the author came up with the idea of an electric rifle, which just stunned everybody. And so when Taser International came out, the Taser actually stands for Thomas A. Swift Electric Rifle. So anyhow, it's kind of an interesting thing. So it is it's considered, it's not a non-lethal weapon, but a less lethal weapon. And if you see how it got approved, if you notice every cop that uses a taser has to be tased. Why is that? Think about that. Why is it? Because you got a 21-year-old super healthy guy that just got out of the police academy. He hasn't fallen over in all the exercise he had to do in the police academy, and then he get tased. So they collected 2 million healthy law enforcement officers and said, hey, this is a safe thing. But when we think about it, who do we tase, or who gets tased? Well, it's typically somebody that is not super healthy, that's been drinking or drugging, who just ran a mile away from the police, beat the hell out of their spouse or loved one. They're all hyped up with adrenaline, and then boom, they get zapped with a taser, which can precipitate, as you see at the bottom of the slide, sinus rhythm into ventricular tachycardia and death. Next slide. So taser baton related injuries, when you get shot with these beanbag rounds, I'll show you what they look like in a second. You can see you can get skull fractures. You can get shoulder dislocations. Or in that bottom right slide, you'll see that the ulna is broken in the forearm, and that's a nightstick injury where somebody puts their arm up, officer comes down with a nightstick, and then breaks their forearm. So anyhow, next slide. So here's your kinetic impact projectiles, and if you can see in the middle, these things are 40 millimeter rockets, and they come out of a weapon that looks just like that. The nice thing about them is they're aimed selectively at the chest and belly. So the mid-thorax, unfortunately, the rudimentary sights or patients move, so you can see that these people have not been shot at the chest or the belly. Here's a jaw wound or a head wound, and it makes a impact that looks a lot like this on the far right slide. So again, this is something that you as EMS providers will not see on a daily basis, but that's what the wound looks like. Here is in the bottom left-hand corner, you'll see a hand grenade with little rubber balls, and that's the injury pattern against the buttocks you can see there. We also have shotguns that shoot a smaller round that come out, and also a kinetic projectile. If you look at the bottom right corner, the girl in shorts, she has a big bruise in her leg, and it says, "Thanks, LAPD." But one other comment with the non-selective use of these rubber balls, not used as much because of the risk of eye injuries and it being a non-selective weapon. It was a lecture from the medical director of Paris, and they used these when I think it was the Yellow Jacket riots about 2 years ago, and in one day they knocked out 16 eyes in the one day of rioting with these rubber hand grenades. So be aware of that. Next slide. So I know we're getting pretty close to the 2-hour thing. Again, I pretty much went over this. There's another injury to the head. Remember, they're considered less lethal. I would always call medical command and encourage people to be transported because of underlying injuries. Next slide. CSOC, here is how they can be deployed. They can come out in canisters like this. They can be shot out of again, a 40 millimeter rocket. And if you look at the pepper spray, the Scoville units, the jalapeno pepper, 2,500 to 10,000, and the pepper spray is 2 to 4.5 million. So Scoville units is the measurement of heat or burn, and they can be quite painful. Next slide. So there's a officer without any face protection pepper spraying. His pepper is always orange. Is pepper spraying your crowd. They can also use pepper foam. The nice thing about foam is it doesn't blow in the breeze. But these are not without consequences. People with underlying lung problems can have asthma exacerbations. You can have chronic lung damage, and also corneal abrasions are a big concern with this. The biggest thing, though, is most people don't die from it. They feel like they're dying from it. It's usually self-limited, about 20 minutes of pain, water, milk, dish detergent, or actually baby soap can help decontaminate. Next slide. Here's one thing that you should be aware of is oftentimes the riders will grab the munitions and then throw it back at the police. They were prepared for this in Lancaster, and they had gloves on or oven mitts because it comes out and it's hot. And so in this situation, here's a guy throwing it back, and we saw it thrown back at the state police in Lancaster. Some of these things bounce, and here's a guy with a tennis racket also knocking it back. You want to be careful putting these people in your ambulance because you're going to really mess up your ambulance. So decon should be done at the scene and definitely done before they come into the trauma bay. Next slide. So horse injuries, all I can say is a picture is worth a million, a million words. And here's a guy squaring off with a police horse, and I know who's going to win that one. Next slide. So hospital considerations. Remember, this is about terror. This is about scaring the hell out of everybody. So my biggest concern is people that try to infiltrate into the trauma bay with a weapon. That's why I would ask that everybody is changed out of their clothes before they get to the emergency department, at least their shirt off down to their skivvies, so that we can make sure that there are no weapons that are coming back into the trauma bay. If you look at what happens in Israel in trauma centers, nobody goes into the hospital without having all their clothes taken off looking for suicide vests. So we're not too far away from the terror that we see in Israel. So if you get asked to take everybody's clothes off or down to their skivvies, there's a reason for it. We'd rather have that weapon, unfortunately, for you guys outside of the hospital than inside with many more people to take hostage. Next slide. Look at that. We did it, and it's 2:01. Bam. Any questions?
Andy Rennie has a question. Do our local law enforcement agencies use any of these devices?
Yes, absolutely. The only one that is not used, and every one that I showed you is used, with the exception we have them, but they're not used, as the hand grenades with the rubber balls. We try to do everything as a selected munition, where the orange shotgun, that's considered your less lethal shotgun. So it'll have a 12 gauge round in there with a piece of foam or rubber. And so, but it's pointed intentionally at a person that is acting out. So it's not indiscriminately fired into a crowd. Unfortunately, when you got a crowd, there's potential to hit the wrong person. It's supposed to be aimed mid-torso, but the more common one that we're using is the 40 millimeter, which is like a big rocket, and we're seeing those also in Lancaster and in Pennsylvania.
All right, everybody. Does anybody have any final questions for Dr. Rehart before we shut it down for the day? If you're prepping for a question, looking for your unmute button, or send in a chat, please remember, if you wish to have Con Ed assigned to your state account, please make sure you make the Andy or I aware via the chat or texting or emailing me your state number, because without that, unfortunately, we can't just blindly assign Con Ed. So please make sure that it's in that chat room.
And thanks again for driving with Dr. Mike.
All right. All right.
See you guys.
All right, everybody. Thank you. Please make sure you put that in. I'll leave the chat open here for about 2 more minutes. Make sure everybody's up there. And once Andy gets me this, you'll see your Con Ed in about 2 days. Have a good week, everybody. Stay safe. Stay warm. Andy Rennie, are you there?
Yeah, I'm here, Rick.